So Judy disappeared, but it's my pleasure today to introduce Dr. Judy Lobo, who's an assistant professor with the psychiatry department at UCSD, and she works with neuroimaging and biomarkers of health among older adults and people with HIV. And she is part of the HIV neurobehavioral research program and completed her graduate training at the University of Miami. So I personally am very excited to hear you speak today because this is like the imaging and the biomarkers. So I'm going to pass it to you, and I look forward to your talk.
Thank you for joining in. Thank you for joining in from other time zones. Thank you for starting the day here, just like I am. I'm here to talk to you about resting state connectivity and its association with HIV, AIDS, and history of methamphetamine use. Like was previously mentioned, I am an assistant adjunct professor at the University of California in San Diego. I'm very happy to work with the HNIP. So of course my talk was going to be about HIV. And I'm hoping to teach you a little bit about methamphetamine use, a little bit about brains. This is a topic that I think is a lot of interest here in California, and particularly in San Diego, since with HIV, there's kind of been mention of there being a double epidemic of HIV and meth use. Meth around here is actually a common substance use, not only among people with HIV, but in the general public. Among the world, it's also one of the most commonly used drugs. So it's perhaps not something that has gotten as much media attention, but I think is something of growing importance. In San Diego County, it's even of more concern than alcohol, cannabis use, and cocaine use. Methamphetamine use is, like I said, according to the CDC, one of the most commonly used drugs worldwide. It's a major factor for HIV transmission as well. It's linked to HIV care gaps. It's linked to zero conversion into HIV. So it's one of the things that we kind of have to be able to study together. There's also an increased likelihood that you will have a detectable viral load if you are a methamphetamine user. When it comes to the brain, much of the work has been done in structural neuroimaging, which means that we have mostly studied how methamphetamine use impacts how thick the gray matter is in the brain. However, of interest to us who are into functional neuroimaging is some of those locations which have been impacted by methamphetamine use also happen to be hubs that are part of large-scale neural maps that we have identified in functional neuroimaging, where we believe that even though these brain regions may be not spatially next to each other, they tend to synchronize together to complete a task. So we have like the executive control network, which includes the DLPFC, which you will see here in the top right, which allows us to carry out executive control function. Methamphetamine, not surprisingly, is also kind of linked to cognitive function as well. Along with these brain regions, there's usually lower connectivity found in between the anterior cingulate and the prefrontal cortex. So the anterior cingulate cortex, which I will now call the ACC unless someone asks me to do otherwise, is also a hub of the salience control network, which is tied to attention. The prefrontal the PFC, or the prefrontal cortex, is also linked to executive control function. So we kind of see this as cognitive control circuitry being impacted by methamphetamine use. The running theory is that those who use methamphetamine require greater engagement of these frontal structures in order to carry out the same executive functions. So these kind of neural effects can also kind of be observed in terms of cognitive function, like in this meta-analysis of several connectivity studies, we found that meth substance use is associated with poor performance in all cognitive domains. So individually, they have been studied in terms of memory, executive control, processing speed. But overall, the effects can kind of be seen as impacted like several of these executive functions. Those who have substance dependence also display poor decision-making and cognitive control and require greater engagement of these frontal structures, according to this Hoffman 2008 paper. The study that I'm about to describe uses this data set collected at the UCSD called the Translational Methamphetamine AIDS Research Center data set. There has been one previous study done in terms of functional connectivity, and they found that HIV-associated reduction connectivity between the prefrontal cortex and those recorded was in the people with HIV when they were compared to the seronegative control group. However, they only found this effect when they were comparing younger adults to adults that were older than 50 years old. But they did find that cognitive impairment was associated with this reduced frontal striatal connectivity between the more cortical and more central features of the brain. So I sought out to use this data set and kind of look at like the wider data set. They have a very helpful design where you kind of have like this 4x4 structure where so that we can look at people who are dually affected by HIV and meth, people with only a HIV diagnosis, people who have a history of methamphetamine use, and then a control group that has neither of those, so that we can kind of determine whether what we're seeing in the functional connectivity of these brain regions is more associated to HIV, methamphetamine, or if they have some kind of synergistic effect. Because of their importance in executive function and because of how often they appear in the literature when it comes to methamphetamine, I focus my study on the anterior cingulate cortex, the ACC, and the DLPFC, the dorsolateral prefrontal cortex. Both of them, again, regions that are important for cognitive function. I had 131 participants to work with. These kind of broke down between these 4 groups. So we have our dually affected group had an N of 31. And the inclusion and exclusion criteria was that they had to have a structural and a functional resting state scan. So what that means for anyone who's unfamiliar is that when we asked people to lie in the scanner, we would have them sit there for 10 minutes and told them that they could just let their mind wander. So there wasn't actually a task going on. So that's why we call these like resting state networks, because we kind of just see what activity is going on during those 10 minutes. There were a few participant exclusions that were excluded after we did a visual check of the scans, and anyone who had significant artifacts were excluded from the study, which brought us down to about 126 participants. Here's our breakdown. We had a primarily Caucasian group, afterwards followed by Hispanic and Black participants. We also, because I work with neuropsychologists, included DDS and RAT scores so that we could kind of compare RAT here being kind of like what their starting point was cognitively, and then included GDS as covariate later. But yeah, here you can see some of our stats, and some of the days since last meth use are the people who were included in the study were usually not current users. Some of them have more cumulative use, like they had used more methamphetamine use over time than others. So like most methamphetamine studies, we did have like a diverse sample. We did pre-processing analysis using the Khan toolbox, which I do recommend. They even have a helpful class. We wanted to specifically look at the ROI to ROI connectivity, meaning region of interest, and how these 2 regions connect. So we extracted the connectivity between the DLPFC and the ACC regions, and we controlled for age and global neurocognitive score. For those of you who are interested, global neurocognitive score here was measured across 7 domains, which are impacted by methamphetamine and HIV, including verbal fluency, executive functioning, processing speed, learning, memory, working memory, and complex motor skills. We then took those raw scores, converted them to T-scores, which were demographically adjusted to then come up with this global neurocognitive score, which is supposed to represent kind of like their whole cognitive functioning. For pre-processing, we removed the forced 4 scans to avoid artifact from when the scanner was warming up. We also had some homogeneity correction. We corrected for the artifact from the scanner. We also corrected for movement from the different directions that the participants tend to move in. Anyone who had an excess of motion was also excluded. We spatially normalized to an M&I template, meaning that we kind of like mapped them out with a like average brain, so we could tell where each brain region was. And we spatially smoothed them with a 6mm isotropic Gaussian kernel so that then we could have better spatial resolution and we were more certain of where we were looking at. This being a correction that is more common among older adults. I had my two brain regions of interest, the ACC and the LPFC. We made a 6 mm sphere around these RMNI coordinates and extracted the brain connectivity from each participant. This is my attempt at making like a more 3D structure, functional connectivity, because it's got these 3 dimensions, tends to be hard to visualize. But here we're going to focus on our findings between the left dorsolateral prefrontal cortex and the more bilateral anterior cingulate cortex, which kind of looks roughly like this in my 3D pink brain. So once we extracted the connectivity between the DLPFC and the ACC, we included in a model which interrogated the HIV by meth interaction while including age and GDS as our covariates. And in this model, and not in any of the models which included just HIV or just methamphetamine use, we found a significant difference between the connectivity of these two structures. Which I thought was interesting because that is kind of consistent with the literature that even though you don't see differences with just meth or just HIV, you do kind of see this kind of like synergistic effect. But when I told my friends and family about this effect, they were like, what do you mean methamphetamine doesn't do anything to the brain? So we interrogated a little bit more deeply into just the methamphetamine group. And among those that had a history of methamphetamine use, we did find that there were significant differences when you look at the ACC as a seed and its connectivity to the whole brain. And it was specifically the connectivity between the ACC and the putamen that has kind of like come up as significant in between these groups. So there are some meth-related differences, but this was only when we were only taking into account the history of methamphetamine use and excluding anyone who didn't have that history. So when we look at the rest of the literature, I will admit that there is kind of like a limitation with who we can compare our results with. There haven't been a lot of functional studies with methamphetamine use. More of it is structural. There has been some work, of course. And in these studies, they have found that methamphetamine dependence, while they were asked to complete a Stroop task inside of the fMRI, is associated with a decrease in connectivity between the DLPFC and the medial cingulate cortex, which is pretty close to our ACC, the dorsal striatum, and several other sensory brain regions. So there does seem to be some kind of like mapping out to other results. We have looked at other substances to see what they have found. And for instance, you have in the alcohol use disorder research that the ACC and orbital frontal cortex connectivity is also lower among individuals that have AUD. They found that the ACC and the hippocampus connectivity was lower for those that had that alcohol use disorder and HIV interaction as well. And they found that the effects of total lifetime alcohol consumption on executive functioning were significantly mediated by the functional connectivity between these structural pairs. If we look at cocaine research, crack cocaine impairs anterior cingulate and prefrontal connectivity in the context of HIV infection. They found that lower activation in the left ACC in current and former users, and they also found lower activation in the left dorsal prefrontal cortex and bilateral dorsal prefrontal cortex. So there is some overlap in regions and also in the direction that there is a dampening in connectivity. Cocaine dependence also modulates the effect of HIV infection on brain activation, meaning that the interaction effects remained after controlling for polysubstance use. So this might be like a broader substance use effect that we're observing. In a previous study that was looking at people who have cocaine use and were diagnosed with HIV, they found that cortical striatal networking deficits were associated with HIV disease and cocaine use, and that functional connectivity in relation into HIV and cocaine use had these interaction effects where it was specifically an AIDS-related effect in the connectivity between the basal ganglia and the dorsal attention network. So we're seeing effects in like the more central structures of the basal ganglia and like more out there cortical structures, which were associated with deficits in cocaine users, but not in the control group. Among individuals with methamphetamine dependence, this risk-related activation in the DLPFC has also been linked to striatal dopamine receptor availability, so leading to more like molecular mechanisms of why this may be happening. In a study that was not necessarily cortical or functional neuroimaging, they looked at spectroscopy in some of these regions, and they found that subjects with a history of chronic methamphetamine use showed lower concentrations of this neuromarker called N-acetylaspartate in the frontal white matter and the basal ganglia. And they also had greater concentrations of something called choline and a glial health marker called myoinositol in the frontal cortex when you compare individuals that have a history of drug use compared to those that do not have a history of drug use. So even though we're seeing functional connectivity effects, there might be more going on in the brain that we still have to explore. In terms of cognition and HIV, we do find that there are also differences in terms of resting state functional connectivity. For instance, among virally suppressed patients with hand or HIV-associated neurocognitive disorder, there are differences in the connectivity between the salience and executive control networks. So back to our brain ROIs, the ACC is part of the salience network, and the executive network also includes the DLPFC. In another study, they also found that increased resting state connectivity between the right cerebral lobule and the ACC was significantly different in the HIV group. This increased resting state functional connectivity was also negatively associated with attention and working memory performance. So there is a reason to believe that the individuals in the study would be impacted by both methamphetamine or any drug use really, and as well as their HIV status. This is important to explore and discuss because methamphetamine use places people with HIV at a greater risk for poor disease outcomes. So having inadequate antiretroviral therapy adherence, faster disease progression, having a greater viral load detected, and ultimately worse global neurocognitive function, which could then translate to more like activities of daily life and being able to manage their own HIV care. So to sum everything up, oops, just to kind of like bring it all back together, the DLPFC to ACC resting state connectivity was significantly different in those that were dually affected by the HIV status and the history of methamphetamine use. This, of course, is based strictly on cross-sectional data. We only had one time point to work with, but we're hoping that in the future we'll have more longitudinal data that we can tap into. But future recommendations include that in order to actually be able to determine the directionality of the effects, to look at more long-term data. We were, however, fortunate to have this fork group design, which allowed us to make comparisons across HIV status and the history of methamphetamine use. So we were kind of helped by our study design. And I also wanted to include this plug. Part of my ethics training this past week, they had me think deeply about what the brain and drug abuse research is how it's being perceived by the general public. And even though we did have significant findings, it's very important to consider the fact that this is research that is still ongoing. And sometimes our samples look very different from each other. So it's very difficult to say what exactly is being impacted by methamphetamine use when the comparison groups are very different. This is very important to consider because, for instance, in the past few years, the methamphetamine use has been kind of leaked into policy. This former president of the Philippines, Duterte, for instance, after hearing that there were structural differences between meth users and those without methamphetamine use, he determined that a year or more of meth use will shrink the brain of a person, and therefore he is no longer viable for rehabilitation. And he actually encouraged the population to take matters into their own hands. And there were several deaths reported by even individuals outside of police officers or anything who actually took to the streets to purge the Philippines of illegal drugs and those associated with them. So please take everything with a grain of salt. We're still figuring out how methamphetamine use is impacting the brain, and studies like these, which also take into account HIV status, I think will help us understand the more complex picture that is really around drug and substance use. So I didn't work alone. There were a lot of people who helped me. I have a lot of great mentors and a great trainee who helped me with the literature search and being able to put my results into the context of others. Also fortunate to have received a pilot grant award from CHIRP, or the California HIV/AIDS Research Program, that helped fund this study. And I'm currently under a NIDA K01, so I'll probably be working on substance use for some time. Okay, so we have a question in the notes in the chat, so I'll start with that. Since ACC and PFC connectivity is hypothesized to affect cognitive performance, why control for cognition in your group comparisons? So I tried it with and without this, because yeah, I was worried that we would no longer see an effect if I included GDS because these are very much cognitive structures. But even if you don't include GDS in the model, these are still significant. And then if you look at the actual literature with methamphetamine use, sometimes you'll see studies where you find these connectivity differences, even though you don't see them in the actual cognitive test. And so part of that is why they're saying it's kind of like a compensatory mechanism that the brain, even though we see the same results on the paper and pencil test, there might be something that we can see in the functional connectivity differences before it becomes behavioral. Because I have seen more studies that find the connectivity differences and not the cognition differences and the other way around. So I still think the real answer is I controlled for it because my mentor told me to. But I still think that it's interesting that the effect remains with or without GDS in the model.
I'm going to ask a question. Could you go back to your the 4-group design, just your kind of table 1 for a second? Just I may have missed it, so I just wanted to take a quick look at the.
So I don't know if you're talking about my demo table
Yeah,
or
yeah,
just
yeah.
okay.
So my question is, yes, you're looking at meth. Is that the only thing that's in the system? Like, what about smoking, alcohol? Oftentimes, like substance, it's not used by itself. Did you collect kind of the data regarding other substances that were used that may have also, confounded or, impacted the results at all?
Yeah, so the data was collected. I believe that anyone who had a dependence on another substance was excluded. So there were
Okay.
even some limitations because afterwards we were kind of interested in what about cannabis use and how do
Yes,
those two
that's what
interact.
exactly.
Yeah,
Yeah.
but we don't actually have enough data, and I think it could be because of those exclusions, because there tends to be a polysubstance use with alcohol and cannabis
Yep.
and meth
Yep.
use. But in this sample, as much as I would like to make those comparisons and see if like cannabis is counteracting these effects, we don't actually have the numbers in this sample.
Okay. Do you
So
have just simple, like, were they smoking, not necessarily from maybe from a clinical like dependence, they were removed, but do you have like use, like
yes,
were they smoking? So those are the types of things that I think would be good to put in your demographic table, see if they differ, smoking, alcohol, basically recreate, things that may also interact with meth. They may just have higher, like it's the curiosity of whether the group that is positive for both is also using these other things, which could be driving. So, I mean, again, as you know, the lives of these individuals are complex. So I would just, you know, take a look.
Lee, I don't know if you're already doing this, but as Judy was presenting, it occurred to me that the complexities of polysubstance use that have been problematic in designing studies and in isolating the signal due to a
Yes.
particular drug is the complexities are actually maybe a strength in using clustering methods
Yes.
often any thought I have you had like 2 years ago, but I am just I'm wondering if anyone's doing that work. But our database, and probably yours, is probably very well suited to taking advantage of what we have in terms of metrics of alcohol use, tobacco
Yep.
use, cannabis use, and everything, and using clustering methods to
Yes.
better understand how they group together, and then comparing those clusters to imaging and so on. So
You're
if you're
talking
not
my
already
ad. You're
yeah, right,
talking
but we're not
talking my ad.
I mean,
Where you could look within
yeah.
each. I've actually done it with Eileen Martin's data many years ago. But yeah, it's spot on. It's the larger databases will get to do those exact same, to do those things, because you're right on point.
Yeah, I think prior to completing this analysis, I would have said that perhaps these are very different in the brain. But now that I've had a chance to go back to the literature, I realize that there's actually quite a lot of overlap. And because there's kind of, I expect similar effects, then I think it would be interesting to kind of see a more complete picture. Not to mention, like you pointed out, these are not people who are just using methamphetamine. These are people who are more likely using more substances. And rather than try to narrow down on just one effect, I think it's better to see how it actually is impacting people and the way it's presenting itself in the field.
Yeah, and I think just for the simplicity of your paper, for this paper in and of itself and your findings, just to add the use of what's there, just so at least you know. I just have a feeling like a reviewer would ask you, if a substance use expert reviews it, they're gonna just say, well, what about this, this, this? So at least you already what those effects are, if they are different across the groups or not. Yeah, but this is great.
Thank you. Yeah, it's something we looked at the greater group, but I think it would be good to look at it, make comparisons in between our 4 groups and see if there's anything there.
Yeah. Yeah, and then Scott, you're there, but then I think of polypharm, where I'm going with polypharmacy and the art reg. It's hard with the small, which is why we're going with this large harmonization across these studies to be able to do that. But those are all the kind of factors that start popping into my head when it comes to, again, it's one substance with others in the background, plus their drug, their non, polypharmacy and the like. I'm going to stop talking. Anybody else have any other questions? I'm always excited to see imaging data.
Yeah, it was very exciting to present. And I made sure to include more neuroimaging details once I heard that you were going to be here, Leah.
Yeah, it's fun to see other folks. And I know your group does a lot of work in the imaging space. So, and Bo presented a few weeks ago. And as you update, please come back and, present. So it's great to be able to follow your work and what you're doing.
Yeah, these are still preliminary results, so I'm very excited to, once the project is more completed, update everyone on what we actually published.
Yeah, that would be amazing. Anybody else have any other? Jenny is, hey, Jenny. Another imager.
Oh, no, I'm not. I don't do much imaging anymore. I do it vicariously through Judy. Very nice presentation, Judy. I was kind of going to follow up on what Leah was talking about with the other substance use, and Judy's absolutely right that we did part of our eligibility criteria was that we excluded dependence on other substances to a certain degree, at least recent. And one of the things that we do have use characteristics, though, and I think we should absolutely look at that. And cannabis is one of the most commonly co-used substances in these groups. And same with smoking cigarettes. I mean, nicotine is a big, and I may have missed that if you already discussed that, but that's also something that might be interesting to look at. But I wanted to go back to the cannabis point. One of my trainees, Jeff Rogers, has published a couple of papers now on the co-effects of methamphetamine and cannabis on cognition, and showing that the opposite effects in HIV, so that meth worsens it, and then cannabis actually the cannabis users have better cognition, and we're seeing a similar effect in some of the biomarkers we're looking at, especially the vascular biomarkers and inflammatory biomarkers. So it's a really interesting combination of drugs, especially in HIV, and I think it's really important to look at in these types of studies. But very, very nice job, Judy. I just wanted to bring that up.
Yeah, thank you, Jenny. Yeah, actually, it was Rowan's paper. I think there was, I don't remember if it was like a review or an actual study where he highlighted that there might be differences between meth and cannabis where they counteract each other. So that's that's one thing that keeps coming up, because I think we expect similar results from people who have cocaine use, alcohol use, but there's something about cannabis that I think we have to really pay attention to what the direction of the effect is, because I think it is possible that they counteract each other. There's some like interesting work out there that says that it could be through inflammation, that meth is causing inflammation because sometimes the brains are bigger than they should be. And so it's possible that cannabis is kind of dampening that effect. So yeah, that's definitely something that has come up. I don't know if we have enough data to actually make some comparisons in between groups, but I think we can at least include it in the demo table, like what the differences were, like if any of these group had like more cannabis use than the other. But perhaps combining some data sets, we could do some very interesting work and see if
That's
there's
what I was
something
just
going on
thinking
there.
about, but I don't know, I don't know what studies have the same, imaging measures, but that would be really interesting. I don't know if there's any literature out there yet. I don't think so, but maybe.
Cecilia, were you going to unmute or no? It's always good to see your face.
No,
but-
not specifically.
Okay.
I just appreciating. I really love this work that Judy is presenting, and I think the main challenge of harmonizing data between cohorts is the characteristics of the collection, the machine, and these kinds of things. But I think that Yulia, you have a beautiful algorithm to put together these things and dissect all these differences in subgroups that I find absolutely gorgeous. And I think you guys should talk, it's really, really cool.
Yeah, and Scott's on here. I see Julie. I
Yeah.
know Rob's in transit from Embarrar back to the States, and Bo is not on here, but he's processing data. I mean, this is part of a MyAd contract it's part of the NNTC to merge and harmonize some of the imaging data with based on what has been collected to hopefully inform prospective studies. So that's why I'm super excited to see. It's like seeing the pieces before they all get kind of put together. And so, yeah, it's an exciting space. So it's a total team effort, right? Raha's on here. I don't know if Yan Shun, there's a lot of people that are involved. Ron, I mean, you name it. The UCSD is very involved in this, as is MIM, Julie. Missouri Institute of Mental Health, Washington University of St. Louis, UC, where is Killian? Thailand. So there's a lot. So stay tuned in that space. Anything else? I love the questions. So thank you, Jenny. Scott.
Will this be the end of the meeting?
Yes, I guess Judy's the only one.
I turned on my camera because I want to look at the camera for this. We have some sad news from San Diego. We learned last week that Chris Akeem passed away unexpectedly. And so we're not sure everyone heard about that, but we wanted to let the community know that had happened. And I don't have details about the circumstances, but I'm sure everyone will join us in recognizing that all Chris contributed to the field, and he was a very good person and contributed a lot to our group. And so we just, I thought it was appropriate to share that news with everyone while we were here together so that you would know.
No, I appreciate that, Scott. And we were very fortunate to get to hear him speak on this, platform just a few weeks ago, to be able to hear kind of the culmination of pulling all of his work together. So we were fortunate in that respect, but it's another thought leader in our field.
All right. Well, thanks, Leah.
We cannot catch breaks. Everybody just needs to stop. Stay healthy. And then, so this has been amazing. And then I closed it for next week. Caroline, I closed I closed
No,
the thing
sure.
for who's speaking next week, so you can.
No problem. It's Luca Shaitaj, and he's at University of Bristol, and he's speaking about leveraging redox dysregulation to target latent HIV infection. And it's the last seminar of the, I guess, the term, the season, and then we're gonna take a break, and then we come back in January.
And so with that being said, thank you, Caroline, as we have another minute or two. Please, 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 you know, I've reached out and a lot of amazing people are on the schedule for the spring, but we still have spots and would love to hear from all of you or your colleagues, your trainees. It's super easy to kind of fill out the form. You know, if you can't find it on our website, we're happy to send it to you, but we do have a number of spots that we would love to have filled because, you know, this is a really great place for this community to come together and, you know, share what's going on. And I think a lot of really good collaborations have stemmed from this and want to keep it going. So please, 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 you know, I'm not going to call out names, but, you know, I'm like smiling at a lot of you because I'd love to hear you speak. So please, please let us know.
Caroline followed up with me about the encephalitis lecture,
Great.
and I need to follow up back with her. But I was asked to prepare a talk on active clinical trials in this space. And so I gave that last week at the HIV DART conference. And so that would be another one that I think I'd like to sharpen a little more for this group, but I think we haven't
That
had
would be
anything.
amazing, Scott.
Yeah, we haven't had anything like that, right? About clinical trials that are going around the country and so on.
No, and I think that would be a really important topic given, you know, the interests here. I see Barb and Rana, you know, there's just a lot of interest in that. So if Caroline, if you want to send Scott the link just to make it easier for him to be able to, but again, you know, please pass it around to your UCSD and every other group that's on here. Hopefully we can fill the remaining spots and keep the conversations going.
I was
So
going
with
to
that,
say, Caroline,
oh.
it might be useful to send that that list out to everybody. Just
Yeah,
to it's
the
on
listserv.
everybody's email today after
Yeah.
Sure.
discussing,
Yep.
because I
Good.
think we still have like 8 or so open
Yeah.
slots.
We do. Yeah, I'll send that. I'll send it to the listserv.
Yep, thanks.
That would be perfect. So thank you guys for attending today and look forward to seeing you all next week. Same time, same place.
See ya.
Bye guys.